right
This
now.
conference will now be recorded.
Just make sure
Okay.
I get good angles, that's all.
We'll work on it. Okay. And this is Joe Gallo from AnCan, and I am supported by several of our premier moderators, in addition to our major presenter for tonight. So we'll get into that very momentarily. I'd like to go through a couple of administrative things. First thing you can do is mute. There we go. Okay. As I asked in the beginning, but not everybody was here at the time, if you will go to your image on the screen, click in the blue dots and change your location or add that to your name, that would be very helpful. Okay, the second thing is go on mute and stay on mute unless you're invited to come off of mute, which may possibly happen when we get into the Q&A session. Okay, so you'll have some opportunities there. I'm also going to ask everyone to turn your cameras off unless you're in the act of presenting or supporting. So that's the majority of folks. That precludes the distraction of either folks watching you sit there and smile or sit there and have your dinner or lunch. But the idea is when you have a group like this, you know, where we've got 60 plus people already, that becomes very distracting while the presenter is trying to go on. So please do that. Any questions that you have that come up during the presentation, you can put them into the chat so that they'll be accumulated by the moderators, and they'll be available right after the presentation. And then if all things go well, we will also have the opportunity for some interactive type chat. We've got some basic guidelines we'd like you to follow, but we'll talk about that when we get to that point. We'll actually be able to talk to the doctor. Okay. Now, before I get going, I got to do the obligatory disclaimer, and that's to understand that any information that you get tonight, anything you hear presented verbally or written, is not intended as a recommendation by AnCan or the presenter. And so we're not really getting into anything that would be called medical treatment. If you have something that you hear tonight that is of interest, we suggest that what you do is you take that to your doctor and work with them on whatever your health program is. Okay. To get this kicked off, I've given them a very short period of time, but our fearless leader, the founder of AnCan, Rick Davis, would you care to say hello?
I would, and I also just want to acknowledge our pharmaceutical sponsors, the totally unbranded Bayer and Pfizer, who support our prostate cancer groups. I think we're the only organization who has any type of virtual group supported, not just for prostate cancer, and it's been a huge boon to our existence, and it allows us to do what we're doing. The other thing that allows us to do what we're doing is we have, I don't know how many now, between 80 and 90 fantastic volunteers, and every icon on that top line, and I think you should turn his camera on just for a moment. But every icon on that top line are people who are incredible volunteers and do a huge amount of work for us. And we are so appreciative, and I hope all of you are too. So if anybody deserves a round of applause other than Dr. Wallis, it is that top line. It's my real pleasure to introduce the introducer. And the introducer today is a man whose where the topic of tonight's discussion is very, very dear to his heart, sadly. And this topic is something that our introducer, Jim Schrate, has lived with since his treatment and has suffered with. And if anybody has the T-shirt about decision regret, I think it's Jim. And I couldn't think of a better person to introduce Dr. Wallis. I should also say that Jim was the former board chair at us too. He now serves on the board of Zero. And we are just thrilled that he's part of our AnCan moderation team. And then if he ever gets off that Zero board, we'll be able to add a few more accolades to his name. Jim, over to you.
Hey, Rick, thank you for your kind words. You've stolen a bit of my thunder, a bit of my story this evening, but I will say that after 12 years now, the shirt still fits. So unfortunately, it's my pleasure to introduce Dr. Christopher Wallis tonight. Chris is an assistant professor in the Division of Urology of the University of Toronto. In November of 2021, Chris and his colleagues reported on their research into treatment regret following surgery or radiation therapy for prostate cancer. This was published in the Journal of the American Medical Association on Oncology in November of last year. I can add a little bit to my story. I won't belabor it. Many of you know Howard's story about choosing active surveillance. I was diagnosed about the same time, 12 years ago in 2010. I was 58 at the time, and I had extremely low volume Gleason 7, 3+4 prostate cancer. I was not offered active surveillance. And in fact, when I asked about it, it was specifically rejected by my treating clinicians. So unfortunately, I chose surgery based on my research and assurances from my treating physicians, which ultimately proved to be untrue. I regretted my treatment choice so much that I developed a clinical depression that took me to the brink of suicide. Fortunately, I was able to get mental health help and get through it and channel some of my anger and negative energy toward trying to help other patients. I'm truly grateful to Chris and his colleagues for their research on this critical issue, and I hope that his findings will help newly diagnosed prostate cancer patients find a better path than I did. So with that, I'll turn it over to Chris.
Well, thank you so much. I think it takes incredible strength to share your story as you have, and I think it will undoubtedly help others. And hopefully, some of what I have to share and some of the work we've done will be able to do similar things. And so I've entitled this Second Thoughts, Regret and Prostate Cancer. For full disclosure, these are potential consulting relationships that may be relevant, but these all pertain to later disease, and we're focusing really on early disease here. And so I think to frame the discussion of regret, we need to first think of what is the goal of prostate cancer treatment, and really we need to think about this and ensure that the goals that the physicians approach this with for any given patient align with that patient's own goals. And so we can think of a variety of different ways that we may contextualize the goals of prostate cancer treatment. And the traditional oncology model, and certainly it fits as we still have overall survival as the key endpoint for most of our advanced disease studies, is to live longer or maybe cure disease. But this is some really interesting work, and many of you will know Hash Ahmed, who is based out of the UK. And he looks a lot at focal therapy, but one of the ways that you can really contextualize all the prostate cancer treatment options are to look at the trade-offs between risks and benefits, because as Jim's sort of introduction framed this, that every decision comes with both pros and cons and risks and benefits. And so typically in prostate cancer, we're trading off certainty or increased confidence in our cancer control against increased risks of side effects and toxicity. And so these authors have done some really interesting work. And one of their key takeaways that I think is often lost on many physicians, but probably not lost on patients, is that patients with prostate cancer are willing to compromise survival to some degree in order to achieve better quality of life. And so maybe when we look at the goal of prostate cancer treatment, it isn't just to cure disease or to live longer, but maybe it's to live better or to maximize quality of life. And in research parlance, we talk about quality adjusted life years, and that takes both into account, where we look at both the duration of someone's life and also the quality of those years. And you can have that taken together in a single measure. And so obviously when we're talking about localized prostate cancer, we look at the 3 standard guideline recommended treatment options, including active surveillance, surgery, and radiation. And if you look at the PROTECT data or other studies, there's certainly good evidence to suggest that the efficacy of these treatment approaches, when properly selected, is probably very similar, and rates of prostate cancer mortality probably don't differ. But we do know that toxicity or adverse events does differ. However, what makes, I think, this harder for decision making, and what really challenges me when I'm counseling patients, is that there is a not perfect correlation between symptoms and quality of life or bother. That is, some patients may have profoundly affected symptomatology, i.e., we could think of an example of erectile function after surgery that is really poor, but it doesn't bother them that much or impact their quality of life because of other things that are happening in their life. Conversely, some men may objectively, to our eye, do quite well and have, maybe only a tiny bit of urine leakage, or be only wearing a safety pad, but either psychologically or physically that causes a great burden. And so this correlation is not direct, and that really makes it harder for us to guide patients and really give a good understanding before we start treatment about what outcomes are likely to be on the other end. And so this is a slide that Alicia Morgan's, one of my friends and colleagues, has shared with me, and you'll see a few others that she's shared as well. But I think many, or hopefully most of us, view medicine in this light today, and that is that patient-centered care improves outcomes. And this, maybe patient satisfaction, and that's probably most intuitive. But we actually know, and we have pretty good evidence, that patient-centered care improves adherence to treatment plans, which also improves objective clinical outcomes, things like pain, psychological distress, quality of life, but also disease-specific outcomes. And in prostate cancer, those kind of things we're talking about are functional outcomes. And this is postulated or supposed to be through a mechanism by which patient-centered care leads to a more informed and engaged patient and family, which leads to improved communication, a better understanding of the decision-making processes, and improved outcomes. And so, cycling back to what our goals are here, I think most of us who treat localized prostate cancer know that, over a 10, 15, 20-year time frame, it's unlikely that most patients with localized disease will die of their cancer. So instead, we really have to focus on quality of life measures, and we, I think, lose some of the nuance sometimes about what this means. And so, patient-reported outcome measures, those are standard metrics that are well studied, things like EPIC scores or IPSS scores, IIEF scores, and then we look at treatment-related adverse events. Those things are relatively easy to measure, and those are the physician measured toxicity metrics, and you see those in the randomized controlled trials. But then there's all this other X factor that, is the anxiety, the burden of treatment in terms of the effect it has on working, the travel requirements and disruption to day-to-day life, the burden on the family, and financial concerns. And I think financial toxicity is increasingly being recognized. And we won't talk about it too much today, but we've got some interesting research that is underway trying to look at how financial toxicity really affects patients' long-term satisfaction with their treatment choices. And so when we're trying to integrate these approaches, we turn to treatment regret as an outcome. And, I think if you step backwards for a minute, you, as a physician, approach the counseling process of a patient newly diagnosed with prostate cancer, and your goal should be to help the patient through the decision-making process and the treatment process such that when they look back, they feel that they made the right choice. And in that way, you'll know that your counseling has been successful. You've helped a patient through the process of the prostate cancer diagnosis and treatment decision-making pathway in a way that sort of is congruent with their goals and their wishes. And so the converse of that, obviously, is patients who regret their choice. Something along that pathway has obviously gone wrong. And so treatment regret or a regret of any kind, is a negative experience, as you will intrinsically sort of grasp. But I think it's important, and this is sort of jargony terminology, but it's premised on this counterfactual. And what we mean by a counterfactual is the imagined alternate reality whereby if you had made a different choice, you can imagine what the outcome of that choice would be. So in all of our lives, you come to the crossroads in life at any particular decision point, and you choose one branch or the other. And sometimes you can look back and think, what life may have been like if you'd made the other choice. And that's that counterfactual comparison between the choice you made and the alternative that you think you could have made. And from our perspective, treatment regret is a really holistic kind of endpoint or study outcome, because a lot of different factors contribute to whether a patient feels regret about their choice or not. It looks at treatment-related functional impairments, so there may be effects on bowel or bladder or erectile function. It looks at the cancer control and anxiety associated with that. And it looks at behavioral, emotional, and interpersonal changes that may be associated with a prostate cancer diagnosis and treatment. And then, as we alluded to, not all patients view these things in the same way. So each of these, when we're looking at regret, is considered through the lens of an individual patient's values and expectations. So, for example, I see some patients who newly diagnosed with prostate cancer for whom erectile dysfunction is not an issue. It doesn't affect their quality of life because they're not sexually active at the time of diagnosis. For other men, the idea of urine leakage is such a burden because they live very active lives, and urine leakage would impair activities that are really important to them. And so those individualized priorities about life help to frame how we view each individual metric. And so this, as Jim alluded to, is a paper we put out this fall looking at this, and you can see it's an illustrious group that I got to work with. This is the Caesar study, and we'll talk a little bit more about what that means. But Dr. Penson is a name you'll probably recognize. Dr. Cooperberg, Dr. Barocas, Dr. Hoffman. These are, thought leaders in the treatment of prostate cancer. And so we had three main theories that we thought to test here. First was that treatment modality, that is what treatment you chose, whether surgery, radiation, or surveillance, would be predictive of your chance of getting regret. And then the second one here is that what your functional outcomes are, i.e. your erections, your urinary control, and your bowel function, may affect how likely you are to express that regret down the road. And that to some degree, we may be able to predict those patients who are going to be developing regret in the longer term right up front by examining their decision-making styles and their expectations. And so the Caesar cohort is a prospective population-based study. And so we identified patients newly diagnosed with prostate cancer in 2011 who were 80 years or less, who had localized prostate cancer, non-metastatic, not locally advanced, and had PSAs under 50. And these patients were all invited to participate in this study and perform surveys at baseline. And what we mean is that at the time of diagnosis, at 6 months after diagnosis, at 12 months, at 3 years, and at 5 years. We've actually just completed 10-year surveys, but those data haven't been collated or analyzed yet. Now, the outcome we looked at here was treatment-related regret, and someone named Jack Clark, a long time ago, almost 20 years now, spent quite some time coming up with a measure of questions to ask patients to gauge their level of regret. And he studied this in a number of different cohorts and really validated a way of testing this that correlated well with significant or severe regret. And so this is scored on a 0 to 100 scale, and significant regret, according to Dr. Clark, is when patients' scores are 40 or higher. And so this, I want to take a minute to stop. This is our flow diagram about how we think about regret. And so regret is the final outcome here on the right. And we're thinking about how the pathway of regret may come to be. And so you come into your new diagnosis, and there's certain things about each patient, their age, their education, race and ethnicity, marital status, comorbidities, and other characteristics that feed into patients' expectations about what treatments will be. This is influenced by their participatory decision-making style, i.e. how they interact with their physicians in the course of making healthcare decisions. Now, obviously, tumor characteristics influences your treatment choice as well, because we know some patients with more high-risk disease may not be good candidates for surveillance, whereas those with lower risk disease may be more suitable. And so these factors all play into what treatment an individual patient will choose, which again affects the outcomes in terms of urinary control, erections, and bowel function that they're likely to get. And these things all contribute, we believed, to treatment regret. And so this is the sort of mechanism that we thought may be underlying what's going on, and we sought to test this with the data that we had on hand. And so this study, I don't want to belabor this flow diagram, but I just want to highlight a couple of things. Number one is that we asked about 7,300 men to participate, and about 3,600 were not interested. So we have about 3,700 patients who formed the Caesar study in total. And some of these didn't meet inclusion criteria. Either they were older than our cutoff, their PSA levels were too high, something like that. So we get about 3,300 men. Now, in this study, we're not interested in patients who received ablation. In 2011 was a pretty uncommon treatment approach, and its size made it so small that we couldn't analyze it well. And we did not include patients who received hormone therapy alone. So now we have about 3,100 patients who received either surgery, radiation, or active surveillance. And the CAPTURE study, which is based out of UCSF and as part of our overall Caesar study, didn't use the same surveys for regret. So we excluded those patients. And now we get down to a cohort of about 2,000 patients. So just to highlight that we've winnowed our study group down a fair bit, and so we have to acknowledge that we're looking at a smaller subset of men, and we may not know everything about these ones that we do for the whole cohort. Now, this is all the background details of the men we examined, and you don't need to look at all these details, but I want to highlight a few things here. So this is the overall cohort, so you'll see surgery in the left column, radiation, active surveillance, and then the overall study cohort. So to highlight here, 45% low risk disease, 38% intermediate, 16% high risk. Median PSA around 5. Most people falling in that 4 to 10 range. Most people with disease that can't be felt on examination, and about half the cohort having Gleason 6 disease, and the remainder spread out over Gleason 7, 8, 9, and 10. So overall, treatment regret was experienced by 13% of men. So that's roughly speaking, 1 in 7 to 1 in 8 men. And these rates were somewhat higher for the patients who opted for surgery, where it was 16%, and lower for the men who opted for surveillance, where it was 7%. And so those are, our overall numbers, but then we want to adjust things because there are maybe other characteristics that affect it. And so maybe we're not making an apples to apples comparison, and we'll never get perfect apples to apples in a observational study like this, but we can do a little better than the raw numbers. And so what we look at, these are adjusted values. And so this is an odds ratio. And what that means is you can think of it as this many times more likely. So in the overall study group, if you had surgery as compared to having surveillance, you were about 2.5 times more likely to have regret after we take into account everything else we know about you. And that's what we know at baseline, and then the second column is taking into account also the functional outcomes, i.e. your urinary control, your bowel function, your erections. So in the overall study, we see that surgery compared to surveillance has an increased chance of having regret. Radiation versus surveillance has an increased chance. Now, I think what's more important, though, is when we break it down by these risk groups. And so we want to look first at the low risk group. And so the effect here is even stronger. So patients who got active treatment with either surgery or radiation compared to surveillance were much more likely to have regret. And we saw a similar pattern in the intermediate risk group, although it wasn't quite as strong. And so you can, postulate as to why this may be. And this kind of study didn't ask patients exactly why they had regret, although we're doing some ongoing work to look into that more. But you can consider, especially given the low chance of the cancer progressing in the first 5 years after treatment for low and intermediate risk disease, that this is likely people are having regret because they had significant side effects from their treatment. Conversely, it's interesting that when we look at patients who have high-risk disease or more aggressive cancers, those patients who had surgery or radiation were less likely to have regret than those who had surveillance. So in these patients with more aggressive disease, not having treatment is more likely to lead to regret. And so the opposite logic is probably true here, where these men are having regret because they didn't get treatment and their disease progressed rather than because they did and they got side effects. Now, this is looking at different things that may predict regret, and there's a whole bunch here. Sexual function, notably, was the only change in functional status that had a strong association. Things like urinary incontinence and bowel function didn't really seem to increase a man's likelihood of experiencing regret. There was, as we saw before, an effect with people who had treatment with either surgery or radiation compared to surveillance. The way that decisions are made, or this is the participated decision-making score, also influenced it. So the more engaged a patient was with the decision-making process, the less paternalistic the physician was, the less likely patients were to have regret. And then this is, I think, where the real meat of the issue is. This is the perception of the treatment compared to expectations. And so let's frame this here. So again, we're remembering that 13% or 1 in 7 or 1 in 8 men are experiencing regret. Now, if a man says that he thought that his treatment effectiveness, that is the cancer control, was much worse than he thought it would be from before surgery, the chances of experiencing regret is now 70%. And if treatment side effects were much worse than a man expected, then the likelihood of having regret is now 48%. So it's this disconnect between what treatment outcomes really are like, whether in terms of cancer control or in terms of side effects, and what a man expects or thinks that they're going to be like that leads to regret. So that disconnect is really important. And I think that highlights some potential avenues for all of us to work together to decrease chances of regret going forward. Now, we want to look at other things that may help us identify patients right at the time of their diagnosis who are more likely to have regret. And so we see again that decision-making style is important, age, so younger men are more likely to have regret, older men less likely. Social support is important, so that's your family, your spouse. We also see that regret is somewhat more likely in the high-risk population because maybe you can argue that there's a bit more at stake here. So it's important to show here, this is a fancy looking plot, but the takeaway is that if you have regret at 3 years, you're likely to still have it at 5. If you don't by 3, you're unlikely to develop it over 5. So these things happen relatively early, and they settle in and they stay for quite some time. And we're going to look at this at 10 years to see how long it tracks out. And I think this is going to be the summary of the first sort of half of what I've got to say, and then we can have a discussion afterwards. But I think the takeaway from this regret analysis is that more than 1 in 8 patients with localized prostate cancer have treatment-related regret. And this is much more likely among men who opt for active treatment with either surgery or radiation than among those who undertake surveillance, although this changes based on the aggressiveness of the cancer, with better or lower rates of regret in the surveillance patients if they had lower intermediate risk disease, and an opposite effect among those with high risk disease. I didn't linger on this too long, but comparisons between surgery and radiation show that there's somewhat higher regret among those who choose surgery than those who choose radiation. And what we see is that a disconnect between a patient's expectations before they begin treatment and the outcomes they experience after treatment contributes more to regret than nearly any other metric, including urinary control, erectile dysfunction, bowel problems, the treatment they actually chose, or any of their disease characteristics. And so this means that treatment regret may be modifiable in terms of the survivorship experience, because we can hopefully address through better counseling this gap between expectations and realized outcomes. And so my belief is that improved counseling at the time of diagnosis and prior to prostate cancer treatment, including a real effort to identify patients' values and priorities, can decrease regret among men with a localized prostate cancer. And now I want to transition to one of, I think, many tools that we have in our arsenal to potentially decrease regret, and that's time. And so we can think about why patients are waiting and how we can utilize that to our benefit. And so you probably all know that due to the COVID-19 pandemic, we had some delays in prostate cancer treatment and in healthcare delivery in general across the world. Certainly the US was not spared, nor was Canada. Health system delays, so certainly physicians that are in high demand often have wait lists that may cause patients to wait. But I'm going to suggest to you that we may just have waiting because we can, and that's not a bad thing. So this came out in the context of the COVID-19 pandemic, and this comes from colleagues and friends of mine in Boston who did a systematic review of the effect of delays between diagnosis and treatment for men with intermediate and high-risk prostate cancer. And this, just to highlight, a systematic review really takes an objective look at all the studies that have been published to date and tries to synthesize them together to give us a takeaway message of all the studies that we have available to us. And this is a little bit different than a meta-analysis, which mathematically combines the results of all these different studies. And so these authors found 24 studies with a huge flurry of them coming out in 2019 and 2020. And the key takeaway here is that there's no worse outcome for men who have delays from their diagnosis to starting treatment. And this shows that treatment delays of up to 3 months are certainly safe, and much longer delays, even for men with high-risk disease, may be not associated with worse outcomes. However, we don't really know the effect from this study on longer-term outcomes because very few studies assess things like survival. And so I want to cycle you back to putting this in context in low-risk prostate cancer, and you guys will know these data as well as any. So this is the Cancer Care Ontario guidelines on active surveillance. This was subsequently endorsed by ASCO and forms the basis of most of the guidelines that are in North America. And the recommendation is for patients with low-risk prostate cancer, active surveillance is the preferred disease management strategy. And we have non-risk adjusted here. So low risk and very low risk are aggregated together here, even though ASCO distinguishes them a little bit. And this is based in large part on work that Lori Klotz has done, and Lori's been a mentor of mine for a long time. Obviously, many other groups, including at Hopkins, at UCSF, the Royal Marsden in the UK, the Prius Group, Miami, and many others have looked at it. But I think Lori has been really instrumental in shaping how we think about prostate cancer and really low-risk prostate cancer in particular. And just to remind you that this is a study of nearly 1,000 men with both low and intermediate risk prostate cancer who underwent surveillance. And this was done in an era before MRI and was done without use of biomarkers, really. So this is relying on PSA, digital rectal examination, and repeated biopsies. And so this is less nuanced, arguably, than what we do today. And yet we see very low rates of metastasis or death from prostate cancer even after 15 years. And so we take that, long-term safety data we know from low risk, and we can look in higher risk, and you can see that in low risk, there's no real association. In intermediate risk, very little happens. But in high risk, there's maybe an inflection where biochemical recurrence rates increase if you wait more than 12 or 18 months after diagnosis before you get treated. And so we sought to look at this in something called the SEARCH database, which many of you will know is headed up by Steve Friedland, who was formerly at Duke and is now at Cedars-Sinai in LA. And so this is a geographically and racially diverse cohort of patients who have undergone prostatectomy. And we focus here on the intermediate and high-risk disease to try and see whether the wait time between initial diagnosis, and we use the date of biopsy, and the date of treatment was associated with worse outcomes. And that could be castration resistance, metastasis, or death. And the takeaway here, you don't have to be an expert to see that when you look at these pictures, these lines all line up on top of each other, which is to say that the outcomes don't change based on how long you wait, whether it's less than 3 months, 3 to 6 months, or more than 6 months. And others have found similar. So this is Hopkins data, and they found no difference in any of these metrics that we would look at for prostate cancer progression. This is work done out of Michigan, and they use the National Cancer Database. So this is a representative sample of the whole U.S. population in nearly 130,000 men. And again, there's no differences up to a year of waiting, even high-risk disease. So I think this really gives us an idea that localized prostate cancer is not a disease that requires rapid decisions or rapid treatment. And so treatment delays are unlikely to cause harm and may provide additional time for decision making. So I don't think anyone should feel rushed into making a decision for prostate cancer, certainly for localized prostate cancer immediately after their diagnosis, and taking the time to consider the options, weigh the pros and cons, to speak to perhaps multiple physicians, get a second opinion, to speak to friends and loved ones, and ideally to speak to patient support groups and understand from other patients and other men who've been through this process what the expectations are for what things may look like after treatment. And that, I think, is really one of our great tools we may have at our disposal that comes relatively easy to help us reduce treatment-related regret. And so to frame this, I think we need to look at types of decision making. Historically, we had quite a paternalistic decision making in healthcare, where a physician would give a diagnosis and tell a patient what it is that should be done about that diagnosis. We have informed decision making, which is theoretically better because a physician is giving information and not prescriptively telling the patient what they should do. But this often leaves many patients feeling like they're out on their own and left somewhat unsupported to make decisions based on information that the clinician has provided. And instead, I think most of us are seeking to take a shared decision-making process, which is iterative, and we provide information, and then we solicit information and try and understand patient values, and hopefully patients can then solicit information from their physician. And this is a back and forth in which the patient's values, preferences, and priorities really shape the options that a physician offers. And in the end, the role of the physician, in my view, is to provide the information necessary for patients to come to their own decision about what treatment option best suits them in terms of their own values, priorities, and circumstances. And so, patients often ask me, doctor, what do you think the best treatment is for me? And my answer, I think, is sometimes frustratingly opaque, because my answer is that there isn't a best treatment option for localized prostate cancer. There are preferable options in any given situation, but there's certainly not one best option. And for men who aren't suitable for surveillance and who need some form of active treatment, choosing between surgery and radiation can often be difficult. And unfortunately, I find that the right choice is going to depend very much on an individual patient's priorities, and so the doctor can't be prescriptive about making that decision. And it really has to come from and reflect that patient's individual priorities and life circumstances. And so this is my last slide, and then I'm happy to discuss treatment regret and talk more about surveillance. But I think treatment regret is somewhat more common than most physicians probably understand or acknowledge. And we know that active treatment, that's surgery or radiation, increases the chance of regret, particularly in patients with low-risk disease, where surveillance is associated with lower rates of regret. And this disconnect between expectations and outcomes really appears to drive patient-reported regret much more than any other factor we could find in our study. And because treatment delays don't appear to harm oncologic outcomes, I think taking the time after a prostate cancer diagnosis before jumping into a treatment plan is one of our sort of easiest accessed ways of hopefully decreasing treatment-related regret. And so with that, I'm going to stop sharing my slides, and then hope that we can have a nice conversation here. I see that there are a lot of comments in the chat. I don't know if you want me to just start taking them on, or Jim, if you want to sort of prioritize ones that you.
Chris, the moderators, Jim and Alexa and Howard will manage that for you.
I think what we're going to do here is first, Chris, I want to thank you for your excellent presentation, and once again for taking on this subject, which I think is frequently swept under the rug, but is very, very important to patients. We're going to give Howard a moment to make an announcement, and when he's finished, I'll get the ball rolling with a couple of questions. And then Alexa and Howard have been compiling questions from the chat, so they will present those questions or call on the men who've asked the questions. And then, Joe, do you want to describe how we're going to handle the remaining questions from the floor?
Alex is going to handle that.
Okay, Alex is going to talk about that, because we will have plenty of time for questions from the floor, from the audience. So that's the plan. Over to Howard.
Okay, well, thanks, Chris, and thanks, Jim, and thanks to everyone for coming. And I'm hoping that you all will join us. I put in the chat box AnCan, the SB group, the Prostate Forum of Orange County, the Prostate Cancer Support Group Canada, the Walnut Foundation in Toronto. We're getting together with some European counterparts and holding a webinar It's going to be at 11 a.m. Eastern US. If some of you are keeping Central European time, that'll be 5 p.m. for you. And hoping that you will join us. We're going to be having an outstanding panel of patients and doctors, including Dr. Klotz from University of Toronto, Dr. Carroll from UCSF, Dr. Crawford from University of California, San Diego, Dr. Bangma from the Netherlands, Dr. Bratt from Sweden. And we're going to be talking about the future of active surveillance. And in the window is it's a link to sign up. If you physically can't attend, there will be a video, but you know, we really want to hear your voice about where active surveillance is going. We've hit 60%, which was unthinkable, let's say 12 years ago when Jim and I were diagnosed. Only 6% of patients went on active surveillance. So we've just hit 60% in the US. And you know, maybe later on, Chris can tell us where Canada is at with that. But that means 40% of patients who are candidates are still undergoing potentially unnecessary surgery and radiation. At any rate, look in the chat window, and there is. Here, I'll put it in there one more time if I can. Let's see. So, okay, so I'm turning this back over to Jim, who's going to start out with some questions.
Okay, I'll start with one question that I'll confess I sort of stole from Howard, but I've already expressed sort of my bias that this issue is swept under the rug far too much. How did you and your colleagues decide to study this and do the research on it? And what was that process? Because I personally am very grateful, and I think the broader community should be as well.
Yeah, so I think it's a great question. I think, so to be totally honest with you, I have to give credit to Dr. Penson and Dr. Barocas. They started the Caesar project now like 15 years ago almost, and they embedded these questions from Dr. Clark in their initial surveys. I showed up and became involved in Caesar much down the line. The data was there. It was part of these surveys that had been done dating all the way back. You know, the first 3-year survey for a patient enrolled in 2011 was done in 2014. So the data had been collected a long time ago, but not analyzed. From my perspective, my view was that we often compartmentalize prostate cancer treatment outcomes a little too much. We look at, you know, cancer control in a narrow silo, and we look at, you know, what is your PSA after your treatment. We look at, you know, urinary function in a little silo. We look at erectile dysfunction in a little silo. But people don't live their life in little silos. People live their life in a real integrated way. And so I was trying to, you know, conceptualize what's the best way of understanding a treatment related experience for a patient. And I think, you know, it's hard to capture that, and the converse of a good treatment experience is that someone has regret. And so we really capture the outcome we're trying to avoid here. But that, you know, the insight to capture this well predates my involvement in the Caesar study. It dates back to when I was a medical student, actually, when they first were smart enough to put these questions into those surveys.
Yeah, Jim, could I do a quick follow-up?
Sure.
Since you asked my question already.
Okay.
Okay, guys.
You know, in terms of people who have these regrets, the outcome could be a variety of things. But you know, you know, what are the biggest reasons for regret, and what can be done to manage expectations and manage things so that fewer people are regretful. Frankly, I think people regret all the time with a lot of things, but what can you do to improve it?
Totally. So I think there's a few things to think about here. Number one is I think there is on some level an underlying sort of personality trait, right? There are some people who always consider the alternative. Some people are more likely to think about what ifs, some people are less likely to. So I think to begin with, there are some people who are more prone to having regret in the long term than others. And that's what we saw when we looked at differences in terms of patient makeup right at that time of diagnosis. And some patients, there were certain characteristics that could predict patients who are more or less likely to. But that's sort of maybe your baseline risk. And then there's these pressures that are put upon you that can take the person who's even not at all inclined to initially have regret and make they're put through such an ordeal that they experience regret. Alternatively, people who are more inclined may need less of a push, as it were, to end up experiencing regret. So that's the sort of baseline. Then the question is, what's the pressure put upon them? That's the treatment itself, the toxicity, the side effects of treatment. Um, in localized prostate cancer, that's typically sexual, urinary, and bowel function. Um, it may also be cancer control. Patients who don't have good cancer outcomes and need other treatments and need many treatments or have their disease progress may be regretful. And so I think to some degree we can, by doing the best treatment we can, decrease the chance of those outcomes. But even more importantly, we can look at making sure that our description of what's likely to come after treatment is accurate and a fair representation. So I saw that, in some of these chat comments, we have people talking about, maybe surgeons are biased to want to have patients undergo surgery, radiation oncologists biased to want patients to get radiated. Someone commenting that they thought that, maybe urologists minimize the chance of erectile dysfunction. I'll tell you how I counsel my patients, but also I think it's really important that patients really are given information that is likely to align with outcomes. And that means that the doctors need to know the literature in general about, what chances are of these events happening, but they also need to know outcomes for the patients they treat. Not every surgeon is the same. Not everyone's going to have the same nerve sparing success, erectile function rates. And so really honestly and openly giving patients a understanding of what it is that life is likely to look like after treatment, I think is the single best thing we can do to cut down on regret. And I think, to be honest, doctors are probably not entirely um, fully equipped to do that. And that's where I think the role of the patient support group comes in, right? Unless you've been through it and lived that experience, there's a certain amount of nuance that the physician just simply can't convey. And so I think, having groups of men who have had prostate cancer treatment and are willing and able to talk to men who are newly diagnosed and give them that information and experience is absolutely um, irreplaceable. There's nothing a physician can do that would provide that um, that sort of lived experience.
Chris, you've generally knocked the cover off the ball on the questions that I was preparing to ask, but I've and specifically regarding support groups and decision making and that sort of thing. You talked a little bit about the problems with physicians and their ability to convey information to patients. Is there something by way of education that would be helpful here?
I think it's a great question. So I think this is a multi-layer issue though, right? There's number one, knowing the information generally. And so that's where, you can cite studies like the prostate cancer outcome study is a historical one. CSER is a more up-to-date one. There's the NC process study out of North Carolina that all give, a physician the information needed to quote at a, overall population level, what the chances are of these outcomes. So number one, people need to know that data, otherwise they can't. So for example, Caesar would say that if you are undergoing surgery, there's about a 50% chance, 50, that you're going to have erectile dysfunction after surgery. About half of men will be able to, over the long term, get back to somewhere near where they were before. 50% of men will be substantially worse, down to no erectile function. And so that's what I tell my patients. I'll tell them that, like, where it's oncologically safe, I will do nerve sparing. So for example, if someone's got cancer predominantly on one side and the other side, the biopsies are clean, I'm happy to do a really aggressive nerve spare on the side that has no cancer on biopsy, do a little less nerve spare on the side that has more aggressive cancer. But that even with an aggressive nerve spare, we expect that, probably up to half of men will not have erections that are satisfying to them, and they're going to need something else done. And so, I think I'm maybe probably on one end of the extreme of how I counsel patients. I think, you may not hear the same from all physicians. I think my general view in life, and it goes into how I approach this, is that you want to undersell and over-deliver. You don't want to oversell and under-deliver. And so I would rather, and doing this study is played into that, but by inclination, I was there a little bit beforehand. I would rather get patients' expectations lower, and then if they can be pleasantly surprised, that's great. But that I don't want to oversell surgery. It also may reflect in some way the practice environment I'm in Canada. I am not competing for patients per se. I don't have, I don't have a worry about filling my OR time or who I'm going to operate on next. And so every patient I see who's newly diagnosed with prostate cancer gets referred to one of my radiation oncology colleagues. They all meet with them. I essentially won't consent a patient for surgery unless they've had a conversation at least with a radiation oncologist. For patients who I think surveillance is the right choice, if they really want treatment, I'm very hesitant to give it. And I will often recommend a second or even third opinion to make sure that it's not something on my end, on the way I'm communicating, on my ability to convey information. Because I think really when you look at it, and this comes to Howard's comment about the differences in rates of active surveillance in different countries, to me, active treatment rather than active surveillance in a very low risk prostate cancer situation is really a failure of the doctor's counseling. You should be, it's understandable that after being diagnosed with prostate cancer, many men are worried. The natural inclination when you hear the word cancer is to want treatment and to have it dealt with, as it were. But appropriate counseling from a physician should be able to convey that in low risk disease, the risks of jumping in to treatment greatly outweigh the potential gains, because these cancers don't have a high risk of causing problems, of spreading, of leading to death. And so we really have good programs and good approaches to be able to monitor. And so to me, it is a bit of a failure on the physician's part if we can't really convey to patients how and why it's safe to monitor low risk disease.
Say Jim and Alexa, we should probably get some of the patients in.
Yeah, I was just going to turn it over to you, Howard and Alexa, to bring forth the questions from our audience.
Well, can I start off with two audience members who have related questions? James
Go ahead,
Anderson, can you sign in, please? Can you
Mm-hmm.
turn on? So James, why don't you get down to it? And Anthony Henry from Toronto will follow with a related question.
Okay. Hold on. Hopefully you can see. First of all, thank you, Mr. Wallis, for your presentation. It was very thorough. Hope you can hear me. Okay. My question specifically is related to men of color. I was looking at all the data that you took in everything. I was taking some screenshots. It was very good. But I'm more specifically interested in any of that data includes any sub studies related to men of color and also gay men on top of it. I know when I was diagnosed, luckily for me, and I just thank God every day that I was able to meet with the right people. I had two opinions, I went to the right radiologist, et cetera. I ended up getting radiation therapy, which greatly reduced my cancer. I mean, I'm 2 years now into it. My PSA levels are well below 0.06 or whatever it is. Okay. But anyway, in terms of, when I see other African American men or men of color, I'm trying to get them to be more proactive. But anyway, are there any studies related to that? And also, too, for gay men, too, as well. Again, these things are not really talked about, but I don't know, have there been any specific studies or even studies related to your topic tonight? Have there been any data related to that? Thank you.
Great questions. We have the data there. I didn't
Hmm.
I didn't dive into it in the slide deck, but first to address your question about men of color. So there's one of the things we found when we were doing the background for this study was a study looking only at patients undergoing prostatectomy that suggested that African American men were more likely to have regret after surgery than white men. That was a study, single center study out of New York. And so that was, one of the key things we wanted to look at. And so we did do analyses and look at whether a man's race or ethnicity was independently predictive. And one of the interesting takeaways from our study is that it wasn't. It was not significantly different between the way we grouped it was white men, African American men, Hispanic men, and then all other ethnicities got aggregated into another category. So among those four groups, we didn't see that race or ethnicity was an important predictor of regret. Although, as I highlight, that is a bit of a different finding than some other studies. I would say that most of the other studies have been smaller studies, arguably less generalizable, we say, so less reflective of the overall population. So we think that our study, by capturing, 5 different regions of the country, both academic practices and people who are treated at private practice centers and community hospitals, we think that our data are maybe more representative of the overall population than a single hospital in one place in the country. But I would say that there's conflicting data out there, but ours suggests that there's no difference between race and ethnicity. Now, your second question regarding sexual orientation or gay men, this was not part of our study because we don't have that data. Unfortunately, I would say, despite this being an important issue, it's relatively understudied. There's not a lot of good studies out there. I think it's a really unmet need in the research community and in the prostate cancer community. Anecdotally, having treated a number of gay men, I would say that my experience is that this highlights two things. Number one is that prostate cancer decision making is so dependent on an individual person's priorities, and so I don't think, and at least in my experience, you can't make broad generalizations about how gay men differ from heterosexual men necessarily. I would say in some respects, I've seen maybe somewhat more prioritization of sexual function after treatment, heterosexual men are maybe more apt to, you know, not be driven by the chance of erectile dysfunction in their decision making, and that plays a higher priority for some of the gay men I've you know, worked with. But that's certainly not unanimous, and I think it really highlights that from man to man, the priorities and the way they view the pros and cons of prostate cancer treatment really differ. And the other thing you've highlighted in asking these two questions is that there's always an intersectionality, right? No person is defined by any one characteristic. It's not that
Mm-hmm.
you are either white or black, and you know, heterosexual and homosexual is unrelated. These things are all intersectional and they all interact with each other. And so, um, you know, there's much more nuance even beyond looking at these groups on their own, but looking at how they play together, and that is well beyond what I would say any study has addressed adequately so far.
Okay. Okay.
Okay,
But thank you,
Chris,
sir.
thanks,
Thank you.
James.
Thank you.
We have sort of a different intersection, if you will, that may be especially pertinent for you, Chris. We have Anthony Henry of the Walnut Foundation in Toronto. Anthony, sign in, please.
Hi, Dr. Wallis. So I think my question has to do with active surveillance for Black men. I'd like to know your thoughts on that and probably how we could improve the knowledge and understanding in the Black community on that. And then a follow-up question is, could you also comment on using US or UK data to make recommendations for Black men in Canada, where we have a universal healthcare system?
Great questions. And so I would say that the premise of surveillance is a balance always of risk of cancer and benefit of avoiding toxicity. And so Black men, in my mind, deserve the same opportunity to avoid the toxicity of therapy as any other man with prostate cancer. Now, there have been long-standing historical concerns about more aggressive prostate cancer in Black men. These, you know, my view of it, and this is not a, I'm not going to say that I speak unanimously for the medical community, but my belief is that a lot of the differences we see in prostate cancer outcomes, particularly in the US, are driven by healthcare systems factors and access to care and the quality of care that men receive, and not due to the intrinsic disease biology. And so I think that if you capture the disease characteristics well, and that's, you know, the testing you're doing, the biopsy you're getting, and the MRIs you're using, that if you've appropriately risk stratified a man, whether he's white, black, or any other ethnicity, that surveillance is a reasonable approach. Now, you guys will probably know Brandon Malhall's data from JAMA showing that even in patients with Gleason 6 disease, Black men were more likely to die of prostate cancer. Dr. Klotz and I actually wrote an editorial regarding this because one of the big things that we see here is a lower use of adjunct testing in Black men, less use of MRIs, fewer you know, biomarkers in addition to their first biopsy. Some studies suggesting even fewer confirmatory biopsies. So what this suggests is that Black men are not getting the same risk stratification. And so the worst outcomes in surveillance are probably because these are not really Gleason 6 cancers. These are higher risk cancers that were initially misclassified. And we know that that's why a confirmatory biopsy is part of nearly every surveillance regime. And so, you know, I think I still go back to Scott Egner's data looking at like 27,000 prostatectomy specimens, that if you characterize the cancer correctly and it's pure Gleason 6, it doesn't spread. It doesn't go to the lymph nodes. We don't see lymph node metastasis, let alone any worse outcome. For anyone who had pure Gleason 6, on a radical prostatectomy. So that tells me that if we can characterize the disease correctly, get the right diagnosis of Gleason 6 low-risk prostate cancer, that it's reasonable to offer surveillance to all men. And that's my view. That's the way I treat patients. I know there are some physicians who practice somewhat differently. Now, in the context of Canada and universal health care, so there's a couple of things. Number one is that, the original active surveillance data obviously the longest cohort is Canadian. It comes from Sunnybrook, although this is not a ethnically diverse cohort. Toronto is an ethnically diverse city, but when you look at the 1,000 men in the Sunnybrook cohort, this is a heavily white cohort. The same is true in nearly every one of the original active surveillance cohorts. But I think when we look at US data, we can be reassured, for example, that discrepancies in race that we see overall in the US disappear when you move to like the VA system where there's equal access to care. And so that probably more closely parallels the Canadian system where health insurance doesn't drive the access to care. And so the US data out of the VA system, I would say, is informative for us in Canada and provides similar reassurance.
So Alexa.
So, Dr. Wallis, I want to jump in with two questions from our audience. And the first one is, let's get real about erectile dysfunction. We got a great question from our audience. So, could you please comment on whether urologists generally minimize the chance of erectile dysfunction when they describe possible side effects of treatment, which may lead the patient to make a decision based upon unrealistic expectations and treatment regret?
So
what do you think on that?
So the caveat here is that I don't sit in the office or clinic with very many other urologists and listen to them counsel their patients. Obviously, I've gone through that process when I was training as a medical student and as a junior resident. You spend time hearing other people's stories. My feeling, and I've seen sort of handouts that some people send their patients home with, is that the rates are underrepresented compared to what our literature would suggest. And I think there was another comment in there that I saw that is embedded here, which is that over time we don't appear to have gotten that much better, unfortunately. The move to robotics is great. I do robotic prostatectomies almost exclusively. I don't really do open prostates. I do other open surgery, but if you compare back to the Caesar study, which looked at patients treated 2011, you look all the way back to prostate cancer outcome study, which is in the early 1990s. So that's still relatively early on the learning curve, where open prostatectomy had like high transfusion rates, and we don't see a dramatically better erectile function. Personally, having trained in Canada, where we do still a reasonable number of open prostatectomies, I think that I can do a better nerve spare robotically. It looks better. The tissue looks better when I'm done. But at the end of the day, the studies would suggest that we're not that much better off, which may mean that to some degree, it's not about the technical surgery part. It's not about how nicely I can cut that nerve away from the prostate, but there's some trauma that the whole process of having surgery entails, and there's the healing process and inflammatory factors that may play in. And so I think in general, doctors want to do well for their patients, and they don't want to scare patients. But some of what that means is that I think often my view is that it's undersold. It's underrepresented, the severity and frequency.
Thank you. I know a lot of our guys feel relieved with you saying that and you being so honest, and I appreciate you being so honest about that. Our next question is actually from our founder. So if shared decision making is optimal, how do we make that happen? Do doctors already have insufficient time for appointments? How do we make time for shared decision making?
So it's a great question. I try to schedule patients strategically. So I tend to not put new cancer diagnoses early in the day. I back end my day with new diagnoses, knowing that it may take me more time than I'm, um, theoretically allotted. So just from a very pragmatic, practical perspective, that's one thing I do. The other thing you can do is split it up. And that goes back to the second half of the talk, which is that we have time on our side. Um, and we don't need to rush to decision making. So I think whenever there's uncertainty, multiple appointments. So, often there's a lot of information with a new diagnosis. You feel a little overwhelmed and, you're like drinking out of a fire hose with so much information coming at you. So try and convey a digestible portion of information and say, you know what, we're going to circle back in 2 weeks' time. We're going to have another call. Between now and then, here are a few websites that I think are good resources. Go read these places. Come back. I'll go over what we're at from my perspective. Again, you can ask some more questions. So you can do that. So that's 2 visits. Then put in a second opinion. So from my perspective as a urologist, I feel pretty good that I can describe the role of surveillance versus treatment, and that among patients who need treatment, what surgery looks like. I don't feel so confident that I'm going to give all the right details about radiation. There's a lot of nuances there now, when hormones are needed, when they're not, how long the hormones are for, how well we can fractionate the radiation. So is it going to be, the traditional is 5 days a week for like 8 weeks, or maybe we're down to ultra hypofractionation. We're talking like, 5 treatments once or twice a week over a couple of weeks. That whole variation, I'm not going to be able to tell a man exactly what radiation looks like. So I get a radiation oncologist involved as a second opinion. If they want another urologist opinion, I set that up, bring them back again for a third visit with me. And so, if each individual visit, you can't get an hour necessarily, but you can, do multiple visits and use the time between those visits to really gain more information, give the patient time to digest the information you provided. And also, when you first get a diagnosis, you may be not even knowing the questions to ask yet. You may not have questions because you don't even know where to start. And so you can use that time between visits to gather some information and hopefully, be able to figure out the questions that are most relevant to making a treatment decision. And so I think anyone who says, your diagnosis is X, in the next 10 minutes, you need to decide what you want to do with your life. That's not the way to go. And that's someone you probably want to seek another opinion apart from.
That's great. And before we throw it back to Howard for more questions, I just want to say that it's great that you encourage patients to be their own best advocate, because that's what we preach all the time here at AnCan. So on behalf of all of our community, I really appreciate that. So Howard, any more questions?
I can throw one in. I can always come up with one. I'm a journalist, so I get paid to ask questions, if not to answer them. But actually, I had an article in the other day in MedPage. I interviewed Dr. David Crawford from University of California, San Diego. And he was presenting a different way to look at PSA. He said, the way we use PSA now is to find candidates for active surveillance, which really isn't what we should be doing. It's, in other words, if you're 4 and above, you're a target. And we'll put you on active surveillance. We'll let you worry a little bit, maybe. We'll give you a ton of biopsies, more than you want. We'll give you MRIs. What he's proposing is something different, to use 1.5 PSA as a cutoff. And he feels that by using that and getting patients engaged at that level, that he can find 70% of the patients who don't need PSA every year, and can sort of follow a model that's used with colonoscopies, and maybe have them come in every 5 to 10 years. I'm going to post that, I think, here, if anybody wants to read it. But anyway, what is your thought about taking that approach?
Yeah, so I think there's a variety of considerations here. So Dr. Crawford has this pathway. I don't know if you've seen Mark Preston's work looking at like a midlife PSA, as it were, either at 40 or at 50 for risk stratification. We know, for example, if your PSA is under 0.5 at 50, the chance of you ever dying of prostate cancer is essentially zero. And any repeated PSAs after that are probably not going to be that informative. So, the other thing to remember when we think about all this is that while we, for the most part, have done PSA screening annually, and that's the approach that most in North America have taken, the European trial that showed the benefit of screening in many cases did like once every 2 years or once every 4 years, depending on which country you're in. So we've gravitated to this once a year thing without a real rationale for doing so. So I think Dr. Crawford's idea of de-intensifying screening makes sense to begin with. And I think there's a trade-off, right? You don't want to miss people. And so that's why he's lowered that threshold. And so what he's essentially done is try to weed out those people who need a lot less attention. And so if your PSA is under 1.5, you don't need that much prostate focus, because prostate cancer is unlikely to be an issue. Now, if you take it sort of to the extreme, I think it goes too far. This approach, I think, however, is rational, and we have to treat it against the opposite side, though, because when you lower your PSA thresholds for doing something, you're going to find more insignificant disease, which is surveillance worthy. But the question is, do we want to do that? Arguably, never diagnosing low-risk prostate cancer would be good. And that's one of the upsides of you doing MRI before biopsy. We can avoid biopsy if you look at the precision study in like a third of men. You increase your diagnosis of clinically significant disease, that is, finding the ones that need treatment, and you decrease your diagnosis of clinically insignificant disease. And so then you spare men the anxiety of a cancer diagnosis and the burden of all of the testing and repeated interventions necessary for surveillance. So I think, there's an upside to using this low threshold and ruling some men out, but the downside of using a low threshold like 1.5 is you're going to have a relatively high number of quote unquote abnormal results, or men with high PSAs that are above that 1.5 threshold, and you don't want to be too aggressive in investigating all of them, because you're just going to diagnose a lot of cancer that's not really meaningful.
Tell you what, thank you. And Alexa, maybe we can ask Bruce Wright to ask his question.
Sure, Bruce, come on down.
Sure. Yeah, I recently had a biopsy and my PSA has been rising. It went from 8 to, I'm at about 9. And so I got a second opinion, and the doctor I talked to said, well, if you're concerned, because there was more cancer found in the last biopsy, why don't you have a PSA every 3 months? And so I did get a PSA 3 months after the surgery, and it was 13.75, and the previous one had been 9.1 and then 8.1. So my question is, do you think that higher number, the 13.75, was impacted because it was 3 months after the biopsy, or should that have been enough time that there might not be an effect from the biopsy?
So it's a good question. The first thing to point out just more broadly here is that there's lots of interventions that can drive up PSA that don't necessarily represent cancer, and that's what you're sort of alluding to. Historically, we used to think even bike riding would be enough to do it. I don't know that the data really bears that out, but certainly that's a thought.
I did ride my bike there as well, and normally I don't ride it there thinking it might have an impact.
Yeah, so that's certainly that's a thought. And then you'll look at like most schedules in terms of PSA testing tend to keep to that 3-month interval. And partly that's driven based on how long PSA stays around in your bloodstream. So you can think, for example, if you do a biopsy and PSA is just a protein sitting inside a prostate cell, you disrupt that cell and it releases it out and the levels may rise. And the question is, how long are they going to stay risen related to that biopsy and unrelated to cancer growth? And so we know that the half-life of prostate or PSA is in the range of 3 days or so. And most things in medicine, you would say that after 6 half-lives, things should be back to normal. So if it's just related to a one-off event, it should be 6 half-lives. So in theory, in the range of like 30 days, everything should have settled itself out. Now there's not, that's not a hard and fast. If there's some inflammation related to the biopsy and there's a healing process related to that, it may not be, you might not just have that spike and then an immediate return. It may be dragged out, but after 3 months, I think most people would feel that it's not directly biopsy attributable.
What I'm going to do, sorry.
I would say, so most people nowadays are following up if a biopsy is not giving us the information we expect, and there's sort of a clinical picture that makes you worried, an MRI is typically the next step.
I'm going to get
Dr. Wallis, we've run up against our close time. Are you willing to stick around a little bit?
Yeah, we can say a little longer if people have questions.
Can I just follow up?
So I think we need to give somebody else a chance.
Sure, go right ahead.
How about Rob Latimer from San Diego? Can you ask your question?
Yes, my question is there a distinction between people that are dedicated to health practices, nutrition, exercise, spiritual life, family support, low stress, and those that have multiple health conditions and challenges in terms of being successful with watchful waiting?
So I think that's a great question. The long and short of it is that there's not a great number of studies, but that social supports do appear to be helpful. There's some interesting research, and we're trying to get a randomized controlled trial going, actually, looking at a lifestyle intervention. You'll probably know that Dr. Kellogg out of UCSD did the meal study, which looked at like a dietary intervention in patients with prostate cancer and didn't find that it affected the cancer metrics. But this is certainly something that we all hope works. I think I am by nature like a scientific skeptical person, and when you look at some of the prior work we've seen looking at like selenium, vitamin E, all these kind of things, we had great hope that they would help for patients with prostate cancer, and they haven't panned out. And so I think it maybe depends on what metric you look at, whether you're looking at better cancer outcomes. We haven't seen that really to date, although you guys have probably talked about the ERASE study, which looked at exercise and surveillance.
Yeah, we had Dr. Cornier speak. We like Canadian speakers.
Yeah. So there's some there's some interesting suggestions, I would say, out of that study. It doesn't really show cancer outcomes yet, but I think the other things you're alluding to are maybe more important in that coping with the diagnosis, handling the anxiety associated with a new cancer diagnosis and the uncertainty that goes with being on a surveillance regime and not having active treatment. And so those things, while there aren't great studies to say it, I think sort of on face value and sort of intuitively would appear to help people sort of manage through that process.
I had a question for somebody who is Mike Lewis in Toronto, Bob Allen. And he's asking, radiation side effects are mostly delayed compared to surgery. Thus, radiation regrets might come 10 to 20 years later. How does your data deal with this effect? Is there an effect?
So I think this is very true. And I think when you look at the prostate cancer outcome study, you see that, right? Differences in urinary function and sexual function that were present at 3 years start dissipating by 5 and are gone by 15. And part of that is that sexual function is obviously strongly associated with age, even apart from prostate cancer. And so, we see that in Protect as well, where the surveillance patients are catching up to the radiation and surgery patients as they age. Now, our study only went out to 5 years. So things that happen after 5 years obviously aren't captured here. We're working on a fresh data set at 10, but that won't capture everything. One of the things I studied when I was doing my PhD was looking at secondary cancers. And so radiation therapy can obviously cause cancer as well as treat cancer. And we know that from, the best data is probably Hiroshima that tells us that big radiation doses can cause cancer. Now the rates are relatively low. So we know that, a chance of having a second cancer is in the range of a couple of percent just independent of treatment because, some people are unlucky and get two. But that having radiation compared to having surgery or having surveillance does increase that chance. And so I think that's one of those probably dramatic events that may cause regret. And that's not going to be a frequent event, but it's going to be a long-term, late 10, 15, 20-year later kind of event that may cause some men to have really profound regret. And we aren't capturing that in the study as we're cutting off at 5 years so far based on the data we have available to us.
So we have a question from Dr. John Antonucci. So come on down, John.
Hello, and thank you for the talk. Treatment regret, or in many of our cases, treatment resentment, can be very painful and persistent. So after we're done learning how to characterize it, is anybody yet thinking about how to treat it?
Yeah, so I think there's two aspects. I think, what I've alluded to is trying to prevent it, trying to get ahead of the game and figure out what we can do to make it less likely to happen. Now, how to treat it, I think, is clearly a pressing priority. I think, Jim can probably give some helpful comments here, but I think one of the things that we as oncologists don't do enough, and I would say prostate cancer is actually in our realm not the biggest sphere here. It's actually bladder cancer patients that have this more, is the mental health burden of both cancer diagnosis and the effects of cancer therapy are huge. And so we don't screen for enough and identify early enough and make referrals enough for a mental health issues related to cancer, period. And so what do we need to do? I mean, I think number one is oncologists need to think about it more, need to be more aware, it needs to be top of mind. And we need to at least have screening tools. So we use something called ESAS, which is the Edmonton Symptom Assessment Scale, that a patient fills out on a tablet when they come and they're waiting in our waiting room, and it pops up before we see the patient, and it screens simple things like, related to mood, anxiety, depression, as well as like physical symptoms. And so starting with just those simple screeners, checking all patients, because, lots of people are fairly good at, certainly in the context of a 5 or 15-minute office appointment, holding it together in a way that the physician maybe isn't going to pick up on things that are going on in life. And so asking the questions, and even asking the questions just in a simple questionnaire or screener that all patients fill in, is probably the first key step. And then you need to obviously act on those data. And I think most oncologists themselves are not going to be able to carry it through for meaningful mental health effects of treatment, but appropriate referrals. And there's a growing field of psycho-oncology for, mental health care providers, psychologists, and psychiatrists who really focus on working with cancer patients.
Thanks, John. Awesome question. Brian Jarvis, come on down. You had a question.
Yes, mine had to do with, setting expectations so I don't have regrets. After radiation treatment with ADT, once the ADT effects go away, at what point will we know what our nadir is? So we'll know where that true PSA bottom is.
Yeah, so it's a great question, and really it varies a bit from man to man, in part because we need to look at not just when the ADT ends, but when the man's testosterone recovers. And so some men get a quick recovery, and some men the recovery takes longer, and you don't really know how effective treatment is been until you have the effects of ADT fully worn off. And that doesn't just mean 3 months have passed since the last injection. It means that you've gotten back to a normal testosterone level. And so that to me is the marker. And I think an under-recognized fact is that not all men, after they stop their ADT, will get back to their testosterone they had before they started it. Some men will remain having a suppressed testosterone afterwards.
Thank you.
Dr. Wallis, I have one more question. So the question is, little research into a second cancer originating in the prostate. More likely bladder cancer, probably metastasizing to the prostate. Do you see more than one cancer in patients with prostate cancer?
Yeah, so I want to clarify here. When I talk about a second cancer, I'm talking about a totally distinct cancer. So for example, we could see a prostate cancer arising from the prostate, and then years later see a bladder cancer that's grown in the bladder. And this is not a prostate cancer that's spread to the bladder. It's not a metastasis to the bladder. It's a second, sometimes entirely unrelated, sometimes we think related because of the effects of treatment from the radiation therapy maybe for prostate cancer that caused it. But we're talking about what we would call a second primary cancer, so a second cancer that is not the spread of a first cancer. So when this is sort of sometimes an area of confusion, when prostate cancer spreads, if it spreads to the lymph nodes, to the bones, to the lungs, when you look at those cells, even if they're in the bones, you look at them under the microscope on a biopsy, they still look like prostate cancer cells because that's where they came from. And so I'm talking about a second cancer that looks like a different organ because it arose in a different organ. And so that's a slightly different question than a cancer that spread.
Sure. Thanks so much for that clarification. Jim, I'm going to pass it off to you now.
Okay. I was very excited to hear your comments about support groups. So I've got to throw in a little plug for something that AnCan has done. AnCan has produced a poster concerning the perceived value among patients of support groups, specifically online support groups. And that's been accepted for presentation at the AUA annual meeting in New Orleans next month. So if you're there, please come by and see us.
That's awesome.
So, if no one else has anything, we'll call it a night. And thank you again, Dr. Wallis, for your presentation. And I hope we see you again.
My pleasure. Hopefully I'll see you
Thanks.
soon.
Thanks all.
All right, bye.
Prostate Cancer Walk coming up September 18th, and specifically Chicago. Last year, I raised over $3,100. I walked privately 11 miles. I'm going to do under maybe 17 to 18 miles this year. I'm going to raise $5,000. So I'm just like doing a little
Thank
bit.
you very
Thank you.
much, Mr.
Thanks, James.
Thank
Thanks.
you, Mr.
Thanks,
Anderson.
James. Good
Thank
to
you.
see you.
You got it.
Dr. Wallis, if you're still there, that was just fabulous. Thank you so much. And we'll get a copy of the poster to you to look at.
Excellent.
Are we hanging in here?
I think with that, I think we're going to thank everybody else for joining us tonight. We had a very excellent attendance. Reminding all that we will have this posted out via our website, out to YouTube, so you'll be able to play it back or be able to share it with others. And with that, I will just ask everyone to, please, if you have any questions or anything that you'd like to follow up on, you can get a hold of any one of us. I'm Joe G at AnCan.org, but just you can feel free to get back to us and we'll see what we can do. And with that, I will just ask the moderating team to hang around a little bit while we say goodnight to everybody.
Night all.
Night,
Thank you.
everybody. Thanks so much for
Thanks for
coming.
coming.
And Hugh, thanks for sharing that you lay off the sex. Very very informative.
Come
That's
on,
great.
Howard.
That's great that he shared that.
You're the
Whoa,
Howard.
I'm just kidding.
You're the one who told me about it.
Yeah, I'm just teasing him.
But
Okay, with that,
I
guys,
haven't had that much
hold on one
sex
second.
on a
I'm going
bike in a long time.